Hey, this is Reba Hodge at Oregon Health and Science University, working with Foundations of EM and Christian Graybo Moore out of Emory and Andrew Perrotte out of University of Kansas. And today we're going to be talking about airway positioning. So as you can see, I have my friend in front of me. He needs to be intubated. We are pre-oxygenating him with a little nasal cannula. I've got my whole setup of all of my supplies ready to go over here. And right now the bed is in a bad position. And so a couple of things we're going to go over. How do I position the bed for myself? And how do I position the patient to align that pharyngeal-laryngeal axis to give me the best straight shot at their airway? So one of the things I always do, I don't know if you guys can tell, but I'm pretty short. So I always take the head of the bed off. Almost every hospital bed, the head of the bed will come off very easily. And I take that and I put it to the side, hopefully where it's not going to fall down. The other thing I can't do right now is reach my patient. And so I'm going to lower the head of the bed a little bit. And right now he's still a little bit far away. And so what I'm going to do is actually slide the patient all the way up to the edge of the bed here, where his head is almost coming off the edge. Sometimes you slide the whole bed. And so now you can see that my patient is much closer to me. He's much more accessible. He's still a little bit inclined, which is okay with me. But I can't see. If I were to put my Mac blade in his mouth, I'm not going to be able, even standing on my tiptoes, to see what I need to see. And so what I like to do is actually lower the whole bed. Maybe even the patient a little bit more, to where the patient's forehead is kind of at my xiphoid process. My elbow's able to stay close into my body where I can reach his mouth without overextending myself with my arm and using a lot of strength. And I can very easily just kind of lean over his mouth and see without having to really stick my face in it, without having to use a bunch of force. So now what we're going to talk about is the patient's positioning. A lot of people talk about sniffing position, a lot of people talk about shoulder rolls, a lot of people talk about ramping. Those are all words that you'll hear in relation to patient positioning. The thing that I want you guys to remember is that you want their oropharynx to be aligned with their larynx. So you want where you're placing the blade inside their mouth near their epiglottis to be aligned with their trachea. The best way to get an idea of whether or not you have this alignment externally is to think about the patient's earlobes being in line with their sternal notch. You want that to be in a straight line. And so right now our guy is pretty good. I think a mistake sometimes that people make is everybody thinks that you have to take the pillow away. So watch what happens when I take his pillow away. His whole head just fell backwards. His neck is kind of hyperextended. And so right now, his earlobes are lower than his sternal notch. And that's going to actually occlude my view when I try to go in and take a look. And so what you want to do really is just get their head flat, earlobes in line with their sternal notch, and then see if you can take a look. So I'm going to take a look at my friend here. I'm going to get all my supplies together first. So I have my ET tube and my flexible stylet. I've got suctioning, I've got my bougie, I've got a bag valve mask with a PEEP valve to attach to it, and I've got my syringe to blow up my balloon. In a perfect world, I'm going to have double suction. I'm going to have my whole airway cart, video backup, everything ready to go right behind me. And so right now, when I open his mouth and take a look, so you guys can see how I'm close to the patient. My elbow is close into my side. And now, in order to lift to see my airway, my wrist is staying straight, but I'm lifting at my shoulder. And that's going to prevent this number where not only are you going to hit their teeth, but your blade is going to slide out of the valleculae where you want it when you kind of jerk back like this. The other thing to note is now that I've taken his pillow away, see how much I'm having to lift his head up off the bed to get my view. And so that may be why it's actually more helpful to leave the pillow in place in a lot of these patients with normal anatomy. It's going to elevate the head and maintain that axis that you want. While you're taking a look, and I have a perfect view now. One other tip to keep in mind in the sort of era of morbid obesity and obese patients is that even a lot of our patients, when they're flat in the bed, no matter how you've positioned them, they're going to have a big, thick neck. They're going to have no neck, and they're going to be kind of scrunched up like so, not in alignment with how you want them. And so somebody with a big, thick neck or a big back of their head that you're just not able to get aligned, one thing you can grab is a shoulder roll. And so I've made a shoulder roll for this gentleman by just rolling up a blanket. And what you're going to do is, in a real world, you might need a little bit of help. Today I'm super strong. Lift up the patient. Get it kind of right in between their shoulder blades under their traps. And you can see now with him on the shoulder roll, this is too much for him. It hyperextends our particular mannequin. But somebody with a big, short, fat neck, that shoulder roll and that hyperextension is going to open up the airway for you. All right, guys, that's all I've got for today. Go out there and get some good airways.